Hi, everyone. I'm Mark Duggan. I'm the head of the Stanford Institute for Economic Policy Research, and I'm really delighted to welcome all of you here today to participate in this discussion on a really important topic, Zika, Ebola, and the challenge of global health security. This event today wouldn't be happening without the support of Stanford Health Policy. There are a number of people here who are affiliated with that program, including Doug Owens, and Doug is somewhere, but there he is, okay. And also without the help from the Stanford Center for Innovation in Global Health, which is represented by Michelle Berry. And Michelle Berry is the head of the Stanford Center on Innovation in Global Health. And so because she has so much expertise in this area, I am just going to step away and hand over the introductions to Michelle. So Michelle, take it away.
Step away. Don't touch me. Good evening, and welcome to this discussion this evening. Thanks to Mark Duggan at CEPR and Doug Owens for co-sponsoring the event. And a special thank you to Jessica Vo, Hector Marguia, and Ben Murphy for all the logistics. For global health to be secure, we need to secure health in the poorest and most vulnerable of areas of the world. We're watched and are actually watching two extraordinary epidemics play out. Ebola in West Africa, in countries like Guinea, Liberia, Sierra Leone, where health systems are poor to non-existence. And we're watching Zika break out in the northeast aspect of Brazil, one of the poorest areas where biosurveillance, access to reproductive care, and health resources were and continue to be severely strained. It took WHO 9 months from the first case of Ebola and potentially the birth of 4,000 microcephalics affected by Zika before a public health emergency of international concern was called. So tonight, we'll hear from two experts to talk about how we can have more creative ways to invest in a more secure and equitable agenda for health, and what type of collective action is needed to strengthen world governance to actually ensure this kind of global health security. So my pleasure is to introduce these two men. They have very large CVs, so I'm going to just take the high points. Larry Summers is the Charles Eliot University professor and president emeritus at Harvard. He was the former 71st Secretary-Treasurer in the Clinton administration, the former director of the National Economic Council for Obama, and also was the chief economist at the World Bank. But more importantly, from a global health perspective, most recently, Professor Summers co-chaired the Lancet Commission on Global Health 2035, which addressed a specific roadmap for achieving a grand convergence of health in our lifetime. He also led a joint declaration to the UN General Assembly with economists from 44 countries calling on leaders to prioritize investments in health, and also participated in the recent National Academy Medicine Global Health Risk Framework Commission, which highlighted a path to pandemic preparedness for national security. Paul Wise is the Richard E. Berman Professor of Child Health and Society. He's a professor of pediatrics and a senior fellow at the Center for Health Policy, the Center on Democracy, Rule of Law, and the Center for International Security and Cooperation. He is also the co-director of the March of Dimes Prematurity Center. From Paul's perspective, he's had many positions as well, but just some high points is he served as the Vice Chief of Social Medicine and Health Inequities at Brigham and Women at Harvard. He was a special assistant to the U.S. Surgeon General, and he chairs the steering committee for the NIH Global Network for Women and Children's and Health. Gentlemen, take it away.
Thanks very much, Michelle. People recognize the leadership that you've shown in the economic policy world, but are less well known are your activities in global health. The Lancet Commission 2013 on Health 2035 was the 20th anniversary of a World Bank report that you led with Dean Jamieson. That was really one of the first major reports to focus on investing in health, and one of the most influential and first to talk about empowering women and investing in education of young girls. The 2035 report that came out in Lancet in 2013 has been influential in a lot of different areas. I think it would be useful to provide context for this discussion to describe what you feel are the critical findings from that report that are most relevant to questions of global health security.
Let me just say that I'm really glad to be here at CEPR. I look forward to being here for the next several weeks, and I'm grateful to you and to everyone else, Mark, who was involved in organizing this discussion. Whenever I find myself talking about global health, I'm always a little apprehensive because I don't actually know that much about global health. I am not a doctor. I am not an expert on disease processes. I'm mostly an economist who's held some senior economic positions and who, when involved with this issue, have managed to get aligned with the right people. Dean Jamieson in the case of the World Development Report some years ago, and in the case of the in case of the Lancet Commission, Dean Jamieson again, and surely our most distinguished member of the commission, Ken Arrow, who made great contributions to the Global Health 2035 report. Let me answer your question by sort of putting this in a little bit of context, going back. In the early 90s, I was the chief economist of the World Bank. And at that time, the largest part of the economic output of the World Bank was kind of a Hoover Institution agenda of disinflation, deregulation, privatization, and establishment of property rights for the developing world. And I think most of that was, at least at the time, my view was that most of that was right and correct and important, but A, the bank had been pounding around about it for quite a while, and B, there was something a little bloodless and not entirely satisfying about it in terms of its lack of connection to the moral agendas associated with development. And so when it was my job to choose a topic for the bank's flagship publication for the next year, I chose, to the chagrin of some, global health as a topic, with the intent of bringing health issues to the attention of economic policymakers, because various health investments, it seemed to me, had very high return investments, with the intent of bringing economic analysis to the health community, because it seemed to me that the kind of cost-benefit analyses and cost-effectiveness analyses that economists could do could make a substantial contribution to better health policy, and with the objective of causing the World Bank itself to be more focused on the social impact of its various programs. I think in the event the project was a fairly substantial success. One of the readers of the report was probably more ultimately significant than the other 120,000. That was Bill Gates, who became interested in global health in significant part through this report, which showed him that the kind of stuff he was good at, taking a complicated thing with high fixed costs and low marginal costs and getting it distributed widely, was applicable to serve a social purpose. And so the report had an impact at the bank. It obviously had an impact on philanthropy in these areas. I think it had an impact on some number of finance ministers as they thought about healthcare spending. And so the Lancet, probably with Dean's encouragement, asked us to form a commission 20 years later to take stock of where things stood with respect to global health. And I would say we reached a number of major conclusions. First, to an extent that is widely underestimated, great progress has been made and is being made. Child mortality rates, which 2 generations ago were 200, and 1 generation ago per 1,000, 1 generation ago were 100 per 1,000, are under 50 today in the vast majority of the world. If the world made far less progress than it hoped to, than many would have aspired to during the 1990s in combating AIDS, it has made far more progress in the last 15 years than could reasonably have been expected at that time, in substantial part because of the development of new therapies. The second conclusion and the large overall message of the report was that if you looked at the broad history of humanity, until about 250 years ago, there was very substantial similarity across the world in healthy outcomes. Basically everywhere, life was brutish and surely short. Child mortality rates were 300 per 1,000. Life expectancy was under 40. With a set of developments beginning probably in the latter part of the 18th century, associated with economic progress, but not only economic progress, you saw a vast divergence to the point where, if you looked in the 1980s, there were a substantial number of places in the world that had child mortality rates that were 10 times the child mortality rates in other parts of the world, and where there were parts of the world where life expectancy was double what it was in other parts of the world. But what we calculated, and we suggested a substantial program towards it, was that with appropriate investments, it would be possible within another generation to achieve what we called grand convergence. Substantial similarity of health outcomes around the world. Child mortality rates on a worldwide basis that were well below the child mortality rate in the United States when I was born. Life expectancies of 70 or more in the vast majority of the world. Reductions in AIDS mortality rates to 8 per 100,000, and so forth. So the primary conclusion of the report was that it was possible in this generation, and it will presumably be the only time it happens in human history, to achieve this kind of grand convergence. The next conclusion was that it was expensive, but surprisingly inexpensive, ultimately, to achieve this. Our estimate of the cost of this was that it would absorb about 1% of the incremental GDP growth achieved according to the IMF's long-term projections in the developing world between now and 2035. That is not 1% extra of GDP, 1% of the increment to GDP that economic growth will provide over the next 20 years. Somewhat less in middle-income countries, somewhat more in the lowest income countries. It followed from that conclusion, and now reaching a more controversial conclusion, that the primary responsibility for financing and improvement in global health care had to be domestic and within country, and that global assistance should increasingly be oriented to global public goods issues, to addressing research and development for cures for the diseases of the developed, or vaccines against diseases of the developing world, where the incentive for all to invest was far greater than the incentive for any one to invest, to pandemic prevention, to investments that operated at the global level. And we concluded that the world was substantially underinvesting in the assistance budgets were underinvesting in the goods, health goods that had substantial global externalities. We concluded also that and discussed the various issues posed by the fact that one corollary of global convergence was that the health problems of the developing world were increasingly going to be the chronic, non-communicable disease problems of the developed world, and noted a variety of behavioral issues that could be addressed through policy, most notably tobacco, where there's still a huge excess mortality burden, but obesity as well. Finally, we endorsed the goal of universal health care, but emphasized that for poorer countries, there were a number of different transition paths through which one could reach to that universal health care. Well,
the 2013 warning about pandemic a lack of capability in terms of pandemic identification and control was borne out the following year with the Ebola virus outbreak in West Africa. There have been two commissions over the past year examining the catastrophic performance of our global health, security, governance in West Africa. And both have identified some central issues to be addressed. One was the inadequacy of current R&D capability around the vaccines and other technologies that will be crucial in containing subsequent outbreaks. That recommendation, and particularly the specific recommendations for how R&D ought to be addressed at a global level, has raised some controversy, particularly how the private sector and questions of public goods need to be integrated at some level. Do you have a particular feeling about those R&D recommendations before moving on to some of the other recommendations that they had?
Look, my biggest view is that the world is way short of focus on all of these issues, on all of the issues associated with pandemic. I don't want to minimize in any way the significance of Ebola, but there are things to worry about that are vastly larger. There's lots of debate in the among people who know more about this than I, about the likelihood of a return of the 1919 flu, a flu of comparable virulence. It's not an unreasonable estimate, and there's a question what you mean by that. Do you mean the same, since the world's population is 3.5 times larger, do you mean by that the same number of people dying, or do you mean by that the same fraction of the world's population dying? It is not an unreasonable estimate that the probability of something in the range of the 1919 flu on an annual basis is 1%. It's not, I wouldn't want to, if you wanted to say you thought it was 0.7% or 1.3%, I wouldn't feel I could argue with you strongly. If you said it was 0.1%, I think that would be a very hard position to defend. And we are talking about then something that could kill surely tens of millions and perhaps 100 million people. And the Stanford football program is substantially more expensive than the WHO budget for pandemic flu. And it's just crazy that we are so underinvested and underprepared. Dean Jameson and I are just finishing a paper in which we attempt to use, some of you, the economists here will be familiar with it, the techniques economists have for putting a monetary value on reductions in mortality. Essentially, the idea is if I ask Mark what his life is worth, he can't give a meaningful answer to that question. But when he decides what kind of car to buy or what kind of job to take, he does answer the question how much he'd be willing to pay to reduce his chance of dying by 1 in 1,000 or 1 in 10,000. And so one can value a life in that statistical sense. And then one can ask, how big a problem is this risk of pandemic? what we calculate, you can argue with every one of the steps in the calculation, but we conclude that pandemic flu as a risk is in the same range as global climate change. And in terms of the expected cost over the next century, and it does not get 2% of the attention or the resources that global climate change does. I don't have strong views on the precisely appropriate bureaucratic regime for organizing the R&D once a pandemic strikes. I think the relevant concept is something Eisenhower said, and I can't remember exactly what he said, but it was something like, strategic plans are always thrown out at the beginning of the battle, but they are nonetheless absolutely indispensable to have in advance. And I think that's the right way to think about. There needs to be a playbook with much more detail for the next time a pandemic's going to come. Who's going to have responsibility for task A and who's going to have responsibility for task B? And yes, it will have to be modified in the moment, but what Ebola showed is that we quite clearly do not have it.
Well, let's, since we're speaking broadly, recognize that the consequences of pandemics are likely going to be immense. And yes, global interest remains intermittent at best. And the levels of funding that are being discussed now, if at all, are relatively inadequate to even come close to the estimated requirements. It would seem that you have some confidence that creating a valuation of a life saved could alter that, frankly, political dynamic within the global policy world. Why do you think that that kind of valuation would actually alter the way people perceive the risk of pandemics?
I actually think, so first of all, I might be wrong. Second, I actually suspect it's less the placing of a dollar valuation than it is adopting a methodology, adopting a legitimate scientific methodology that suggests that this is a problem of comparable importance to global climate change. Is actually, I think, the important polemical point in not deciding whether it's this many $1 trillion or that many $1 trillion according to a somewhat artificial methodology. I think it's the ability to compare it to other problems of substantial magnitude that I think is very important, and I'm sort of optimistic that it will have some of that effect. I think, look, I've believed something. On a large number of things, I basically disagree very profoundly with Milton Friedman. But he said something about the role of academic economists with respect to policy that felt right. He said, things don't happen just because academic economists, I'm putting words in his mouth, but I think I'm capturing the essence of the thought. He said, what a lot of people think is the idea is they do a study and then they persuade people and then the world moves. That doesn't happen so often. What actually happens is that people do studies and they decide things and they make recommendations and they design approaches and whatnot. And they kind of sit there. And then something happens that creates a political imperative. And when the political imperative is created, they look around for ideas to fill the political imperative. And where the studies have been done and where there's the knowledge, it fills the void. And so it's a kind of inventory waiting for political moments. Now you could say, what good does it do to highlight the importance of pandemics if the political moment's only going to be after the pandemic? Everybody's going to know after the flu comes that we ought to fight it. But I don't think it works like that. I think there are leaders who are looking to embrace a problem that hasn't been the problem focused on by their predecessors, for example. There are people who are looking to make their mark in various different ways. So I think of this kind of knowledge as less you're going to go present it and then somebody's going to do something, but that because it's there, when there's a moment of opportunity, the world's more likely to get to a good outcome.
One of the central challenges, one that I worry a lot about, to the deliberation of pandemic control is the fact that many of the areas of greatest concern are characterized by chronic political instability, conflict, very weak governance, what some would call fragile states or failed states. In fact, almost half of all under 5 mortality in sub-Saharan Africa today are in fact occurring in places characterized by these political challenges. How do you see the conversation, the deliberation, the development of policies around pandemic control that would attend to the requirements of working in these areas and not fall victim to basically policies that are creating, trying to erect walls, which are popular these days, to protect industrialized societies from infectious outbreaks that are occurring or at least originating in these areas?
You ask all the hard questions. I think it's a mistake to think that you're going to make anything too terrific happen in the midst of a failed state. You know, in finance, there's a principle called sovereign cover, which basically is that, and there's some exceptions to it, but it basically is that a company in a country can never borrow at a lower interest rate than the country can. So if you're a Brazilian company and Brazil is a risky place, and so it has to pay 3%, 4% more than the U.S. Treasury would to borrow in dollars, well, that kind of sets a floor for companies borrowing. Well, that kind of principle is more broadly applicable, and that's why I think you're not going to really get to great health outcomes until you make those kinds of states be better. I think what you can do is establish, and I think, by the way, that there is something to, the old principle of quarantine is a central thing with respect to infectious disease, and so I don't think one should entirely condemn the notion of separating the health, of seeking to achieve some separation of the healthy. I think the world has been fortunate that there are a not insubstantial cadre of very brave, medically trained personnel who are prepared to go into these places and are prepared to try to contain these these problems. But I think it would be disingenuous of me to say that you can solve these problems without, in some way, containing the failed state aspect. I mean, look, as you know better than I, because you've really done medical work in these areas, there's always a great tension when you think about how you should prioritize the use of resources between two kinds of approaches. One of which I'll call the McNamara approach, and the other of which I'll call the standard bureaucratic approach. And, the McNamara approach is, let's choose a well-defined, well-measured problem. We want to eradicate river blindness. We want to eradicate smallpox. We want to make family planning universally available. Let's choose a clearly defined objective, and then let's just go do it. And let's hire a set of people to do it. Let's make that be their priority, and let's do it. That's one approach. Another approach is to say, isn't that really kind of stupid that the right place for people to get their immunization against whatever disease you're trying to eradicate is at the health clinic. And while they're there, they should also get immunizations for other things, and they should also get checked. And so what you need to do is make the health system work, and that if you don't make the health system work, no particular siloed offensive you propose to mount is ultimately going to be very effective and important. And surely it's a crazy health system that has 20 disease-specific czars driving programs. On the other hand, there's a sense that putting money into developing country health systems is like putting money into urban school districts. You kind of put the money in, and if you don't have anything, you don't exactly know what comes out. And how you find your way through that balance is one of the great questions. I think it's probably fair to say that most people go into it with a little more of the McNamara view than they have after they've been in it for some number of years. And a very good example is Bill Gates, who was very impatient with people who wanted to yeah around about we need to develop better institutions, and has over time, and wanted to know what the problem was and what the thing we were going to distribute was and to get it distributed. And he has over time come to be much more recognizing of the importance of strengthening institutional development.
I'm going to ask one last question before we open it up to the audience, because I want to give everyone an opportunity to participate. We have a lot of students in the room, and some faculty, the students and faculty trying to figure out what to do with their lives, and some considering a career in economics. And I know many of them, and I know how they're thinking about it. And they tend to see economics as fairly abstract and highly analytic, technical, with lots of math. But when you read what you have been writing about global health, and I've always been a student of yours, but particularly in the last couple of weeks, I've been reading a lot more carefully much of what you've written. And what comes through is a deep humanity, and I would dare say a passion for the moral logic that really provides the infrastructure of your arguments, of your analyses. And it's quite striking, I think, when you read it that way, particularly the recent Declaration for Universal Coverage. Could you provide some counsel to the people thinking about these issues and about a career in economics of where you find the motivation and the rewards to pursue this kind of work, particularly in the global health arena?
You ask hard questions. I guess I'd say a couple things. One, I have always believed, perhaps both my parents were economists. Ken is my uncle, so it was probably part of how I was brought up, to believe that you can count and you can care, and that there's nothing about counting and using numbers and analyzing that means you don't care in a moral way. And indeed, I think I even have come to believe that the more important the issue is, the more important it is that you count and analyze well. If the issue is, should the government issue 5-year bonds or 10-year bonds, it's better to analyze the question accurately and to figure out what the best thing is for the government's financial structure. But if the issue is whether people are going to live or whether people are going to die, it's really much more important to get that right. And I think another thing that I've come to is, and philosophers have been much more profound. People who study the trolley problem have engaged with what I'm about to talk about in a much more serious way than I am now. I've come to believe that things are not less real because there's a long causal chain than if there's a short causal chain. So if one can work with the patient and save the patient's life, and then one has a very profound and direct sense of what one's done, or one can influence the allocation of resources that accelerates in a small way a productive, vaccination program that has the possibility of saving 100,000 lives. And one can see that program having been accelerated by 4 months, perhaps related to one's efforts. Well, you don't see a grateful patient or a grateful beneficiary, but the impact in making the world a better place and in enabling people to survive and to avoid grieving the loss of a family member is as great or greater. So it seems to me that if one has the moral imagination to see, to know there are benefits, even if one is not seeing directly the beneficiary, and one has the logic to recognize that you've got very large quantities of human effort being allocated where there are huge stakes, that one should want to do that as well as one possibly can. And so that's why I went into economics, and that's why part of what I've done in economics was to work in this area. And that's why I encourage my students, encourage large numbers of other people who feel socially committed to go into economics. I think there is an issue. I think there is an issue for the economics profession, which I must say I have been struck by in recent years, which is we do erect in first-year PhD training in economics what is now a very substantial barrier to entry. If what you want to do is better cost-benefit analyses for the design of better health outcomes in global health outcomes in developing countries, we do require you to develop facility with a set of quite elaborate mathematical tools.
We have organic chemistry
that are
as a barrier to med
yeah,
school.
that are in fact not very related to what you're going to do. And whether we have, whether that's, I sort of go back and forth as to whether I think that's a problem with the design of the economics PhD, or whether we need to find ways for people to be well-trained in public health economics and not have an economics PhD, and that's the right solution. I'm not confident I know what the answer is, but I do encounter a fair number of young people who want to do things in the direction of the kinds of things I've done in global health, or want to do things that are addressed at some of the issues that I've worried about at different points, having to do with responding to recessions and the like, but who don't quite see themselves doing all the things you have to do in your first year in graduate school. And I'm not quite sure what the solution to that is. I think it is a bit of a problem. I think there is a bit of a problem there at this point.
Thank you. We'd like to open this up, and you have questions, please.
Hi, my name is Monica. I'm teaching a biosecurity class here at Stanford, which basically has to do with being able to respond and being prepared for infectious disease disasters, i.e. pandemics. So we all know that investing in healthcare is the right thing. You've shown this in your report. Nevertheless, we have also all seen that we are, as a world, as a society, underinvested in global health. Now we see more money flowing in public health because for one of the first times in recent history, Ebola has shown that it can destabilize borders, right? So for the first time in the history of United Nations, public health made it to the agenda. Now the White House has a dedicated person who is working on the agenda in global health security. You've also mentioned that WHO budget to respond to pandemics is minuscule. And this is partially a pattern, really, because we have seen that interest, when there's a pandemic, everybody is rushing to the rescue. And when there is a period of lack of pandemics, the budgets decrease markedly, leaving us unprepared for pandemics. So, granted, we believe the risk of pandemics will only increase with technology development and with globalization, as we have seen in Ebola. That's why Ebola was what it was. So how do we make investing in healthcare sustainable and consistent rather than characterized by these intermittent flurries of activity?
Thank you.
Look, I think the first thing you have to, I don't think there's really an answer other than sustained analysis and advocacy, and eventually it does have an impact if it's credible and credible and persuasive and right. And I think it takes both parts, by the way. You know, the evidence on the psychology of persuasion is kind of overwhelming that a story is worth 1,000 statistics. And so I think you need statistics so that people who are influenced by the stories believe them. But I think it's naive to think that statistics alone are going to move things. I would say I've been both academic with views, and I've been a policymaker in government feeling those pressures. I would say and you know, there are other people here who have as well, and so they might or might not agree with this. But I would say in general, it'd be a good idea if advocates tried to understand better the pressures of the people they were trying to persuade. You know, they're not sitting in their office waiting to de novo do something because somebody came in their office and told them to do something. They're functioning in a bureaucracy with the objective of getting promoted, with the objective of advancing the interests of their president, with the objective of completing the budget cycle in which they're engaged. And so some effort to channel advice in a way that understands the real objectives of the person who's being persuaded, who's to be persuaded, would I think be useful. I think there's always a question, and you can argue back and forth on this. If you're an advocate for more resources for X, what the person who is listening to you is likely thinking is, yeah, I would like to spend more resources on X. It would be good, but I have a budget constraint. I only have so many resources. Where am I supposed to get the resources from? And there's a tendency in advocacy communities to regard that as being not their problem, or to give a kind of non-operational answer. The Pentagon's got too much money. Well, you know, if you're sitting there and you're the Secretary of HHS and the question is, should you put more money into the NIH for preparing for the next Ebola? The observation that the healthcare advocate in front of you thinks the Pentagon spends too much is really not overwhelmingly helpful. And so I think in general, if part of what you're asking is how advocacy can be more effective, I think trying to understand the bureaucratic, the imperatives and the constraints of the person to whom one is advocating would, I think, serve a lot of advocates well.
Thank you. Megan?
Thanks very much for your remarks. My name is Megan Palmer. I'm a senior research scholar here at the Center for International Security and Cooperation, working on issues of biosecurity and global health broadly. I wanted to press you a little bit on what are the critical elements of a strategic playbook that's being in the waiting to be thrown out, if you will, waiting for the political moment. When it comes to global health preparedness, that you think that universities in particular are strategically poised to develop, especially under the current funding priorities. What types of questions inside or outside economics are most salient to be developing now? And also what particular types of partnerships might make the development of those research agendas much more relevant and much more likely to be taken up when that moment does arise.
Thank you.
Look, I think it's, I think that there's probably an underinvestment in almost every aspect of the science relevant to vaccines. And I think there's an underinvestment. I mean, look, I think there's a basic problem, which is if you develop a product that is only useful when there's a really big emergency, you've got a problem, which is when there's a very big emergency, the world's not likely to be willing to let you make a profit. So my bright idea is I'm going to have a really big inventory of snacks, so that when there's a blizzard, I can sell them. Well, I'm sort of performing a useful function by being ready to sell the snacks when there's a blizzard, but in fact, the world won't let me sell them at a huge premium, so nobody does it. And the world lacks that contingent capacity. Well, I think that's the basic insight around a lot of these questions in terms of preparation. And so I think what you need, I don't think there is a terrific solution other than trying to find ways, and I don't know enough about it to know what those ways are, for marrying standby capacity to respond to pandemic with some ability to do things that are useful in the meantime, because you're never going to get paid, you're never going to get resources that are proportional to the value of everybody's going to say, thank you very much, it's good that you developed this. But now that we've got an emergency, we've just got to deal. And so I don't think it has I don't think there is a terrific solution to the problem. It's a very interesting issue. There's been a substantial amount of development and discussion, and the World Bank has the Japanese government actually financing a certain amount of this, of private sector capital markets reinsurance type capacity. So there are facilities that sort of respond to this problem in a way where a country, or in the current environment, an aid donor, pays a premium each year to an insurance company. And the insurance company then, if a set of events happen, triggers the payment of a large amount of money. And so, in a way, by framing it as an insurance problem, you sort of solve that problem. Now, the question about, and I think there's a lot more work to go into developing these schemes, the problem is that if you have an event where there's a 5% chance that you'll have to pay $1,000, you'd sort of think that the premium should be $50. There'd be a way of thinking where the premium would be $1,000. And in fact, the premium would be $1,200. It would be $120, let's say $50. So the premium would in fact be $120. And so then the question is, you're the aid donor, is it really better for you to pay $120 each year? So in expected value, $70 is going to this mechanism, and $50 is going to fight your cause, or are you better off keeping a fund around and responding to to emergencies? But that's the kind of, from an economic point of view, I think that's the that is the central problem, and I guess I would keep very much in mind this concept I introduced of dual use.
Well, I want to thank you all for coming this evening. Thank Mark and SEPR, particularly you, Professor Summers, for a remarkable hour of conversation. Thank you.